Well, good morning, everyone. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. We'll start with just a couple reminders and logistics for the day. So next week, we will be hearing the talk, Doctor, My Bladder Leaks. How can you help me? An update on treatments for female urinary incontinence, and that'll be given by Dr. Sarah Boyles. And now for a few logistics. Grand Rounds is a joint effort between Providence St. Vincent Medical Center and Providence Portland Medical Center. And we are here today on Teams Live. Many weeks we will have our talk available on Tuesdays, live in Southern Auditorium at St. Vincent, and occasionally live in the auditorium at Providence Portland on Wednesdays. Please stay tuned with the weekly invite, which will always indicate the location. And again, you can earn CME credit by being with us live in the room, here live on Teams, or by watching a recording of the event. And the recording is available at the same link as the Grand Rounds weekly invite. I'll be monitoring the Q&A throughout the presentation, so please feel free to go ahead and post any questions or any comments that you have for our presenter. And now I am delighted to introduce today's speaker. We are joined by Dr. Kamal Shuman, who is Assistant Professor of Neurology at the Mayo Clinic College of Medicine and Science. Dr. Shuman earned his residency training in neurology at the Detroit Medical Center, Wayne State University in Detroit, Michigan, and then went on to do neuromuscular fellowship at the Cleveland Clinic, followed by autonomic disorders and peripheral nerve fellowships at the Mayo Clinic in Rochester. Dr. Shuman is a diplomat of the American Board of Psychiatry and Neurology, as well as a diplomat of the American Board of Electrodiagnostic Medicine and the United Council for Neurologic Subspecialties for Autonomic Disorders. Dr. Shuman is currently an autonomic and peripheral nerve specialist at the Mayo Clinic in Rochester, Minnesota, focusing on autonomic and somatic peripheral neuropathies. We are so delighted to have him join us today and do some teaching around this often challenging and somewhat mysterious to many of us topic. Thank you so much for joining us, Dr. Shuman.
It's my pleasure and honor to be here with you today. Thank you, Dr. Letcher and team, for inviting me. Very excited to talk to you about autonomic dysfunction. So let's get to it. I'm happy to take any and all questions at the end, but if you want to interrupt in the middle and ask me any questions you like, I'm also happy to take a moment to answer. So we'll talk about autonomic dysfunction today, but in reality, autonomic dysfunction is a huge topic. We could sit down and talk about autonomic dysfunction for hours. So what I would like to, the way I would like to design our talk today is to suggest an approach to autonomic dysfunction, how I think about it, overview of autonomic testing, and we'll talk quite a bit about autonomic testing, not because I expect everyone to be an expert or have easy access to autonomic testing. It's just because, to me, it's a very good tool to show how the autonomic nervous system works and how those various conditions of autonomic dysfunction can be assessed. We will also, for most of the talk, have case discussions of different types of autonomic dysfunction, primarily showcased through testing and testing results. I will focus today on the cardiovascular autonomic impairment, including orthostatic intolerance, conditions that you could be faced with, including orthostatic hypotension, orthostatic tachycardia, and syncope, to make it more worthwhile and more informative. So as an introduction, what's autonomic dysfunction? Well, it is impairment of the function of the autonomic nervous system. And what is that? Well, it is a network of neurons and nerves, both centrally in the brain and the spinal cord, and also peripherally in the autonomic ganglia and the autonomic nerves, that pretty much go all over the body. The way I explain it to people, it's a mesh of nerves, goes all over your body, innervates many of the vital organs, and does things for you pretty much automatically. When it doesn't work well, when it is impaired, the dysfunction can be manifest with orthostatic intolerance, so feelings of lightheadedness or pre-syncope or even syncope upon one's feet, which can be associated with a drop of blood pressure orthostatically, orthostatic hypotension, or an increment of heart rate upon standing, like postural orthostatic tachycardia, and so on. But it also can manifest, autonomic dysfunction can manifest with cardiac denervation, as in diabetic autonomic neuropathy, for example, neurogenic bladder in people with various types of autonomic impairment, lack of sweating or anhidrosis, which can predispose one to heat exhaustion and stroke and so on, gastrointestinal dysfunction, such as early satiety and gastroparesis and so on, and fixed and reactive pupils, especially in certain cases of ganglionopathies. What are some of the causes of autonomic dysfunction in general? I like to approach these in the pattern of autonomic dysfunction they produce. In cases of generalized autonomic, that's small fiber, because most of the fibers of the autonomic nervous system are small, as opposed to the large nerve fibers that help us with motor function, for example. Sometimes called pandysautonomia, can be seen in cases of diabetes, amyloidosis, Guillain-Barré syndrome acutely, and certain genetic cases like hereditary sensory and autonomic neuropathy type 3. It can also be seen as a pattern of autonomic ganglionopathy that can affect the ganglia all over the body in a patchy manner, which can be seen in diabetes, and also certain autoimmune conditions like autoimmune autonomic ganglionopathy that in certain situations can be associated with alpha-3 subunit ganglionic acetylcholine receptor antibody. It could be a paraneoplastic sort of the phenomenon. And also in a lot of degenerative conditions, neurodegenerative to be exact, like multiple system atrophy or other alpha-synucleinopathies. This still pattern of involvement of small fiber, such as autonomic dysfunction, as you would see with distal small fiber neuropathy. So those people may also have somatic sensory dysfunction, like pain or numbness or tingling in the feet or in length-dependent manner. But with it, there will be a certain amount of autonomic dysfunction, such as anhidrosis in these areas, or a partial type of adrenergic impairment, as in cases of neuropathic POTS. And we'll showcase one of these later. This can happen post-infectiously as well, or post-vaccination. And we've seen that now in the COVID world over the past 3 years. We can also have selective or limited types of autonomic neuropathy, meaning you don't necessarily have to have all autonomic function being impaired. You can have very selective types of autonomic function being impaired with the rest of the autonomic nervous system doing well, such as chronic idiopathic anhidrosis, which is a condition where only the pseudomotor function, SUDO, that's sweat, is impaired. Everything else seems to be intact, and that could be a benign limited condition, or it can have other types of etiologies. Adrenergic neuropathy can be seen, including in diabetes or post-infectiously, where the only problem is with the autonomic nervous system functions ability to control the cardiovascular adrenergic function. Impairment can cause things like neurogenic orthostatic hypotension. Gastroparesis can be also isolated in that only the enteric autonomic nervous system is affected, or maybe just part of the vagal system is affected, causing only gastroparesis, while the rest of the autonomic nervous system is spared. Autonomic neuropathy, in quotes, with CNS involvement. What I mean by that, it's not really a neuropathy, it's not nerve impairment. It is impairment of the autonomic nervous system stemming from a central nervous system disease. Usually the poster condition here is multiple system atrophy, with atrophy of multiple areas of the brain, causing orthostatic hypotension and a plethora of other problems in the autonomic nervous system. But we can also see that autonomic impairment in other alpha-synucleinopathies, such as Parkinson's disease or Lewy body dementia or pure autonomic failure. Also, we can see impairment of the autonomic function in spinal cord lesions, especially high thoracic or cervical, such as autonomic dysreflexia, but also other types of autonomic problems. Paraneoplastic syndromes, drugs like chemotherapy can cause impairment of the autonomic nervous system, and certain toxins like thallium and so on. So how do we evaluate for autonomic dysfunction? Well, good old medicine, right? You start with history. A patient comes in, they have an autonomic sounding type of a chief complaint. You really want to sit down, listen to what they have to say, especially that a lot of these can be vague and sound like a lot of other conditions, especially that it can affect much of the bodily systems. So good history, complete autonomic review. So ask about all of those things that go wrong, from pupils to sweat to gastrointestinal to genitourinary types of impairment, and also other neurologic and cardiac types of comorbidities that could give you a clue about the etiology. A good generalized general physical examination and neurologic examination is in order, and orthostatic vital signs, really important. They don't take that long to do in the office, and they often missed up until the person gets something like a tilt table study, like, oh, you have orthostatic hypotension, orthostatic tachycardia. That's why you've been lightheaded or dizzy on your feet for so long. It could have been avoided by doing good physical exam, including orthostatic vital signs. What are some of the manifestations of cardiovascular autonomic impairment that one should inquire about? Well, you can ask about resting tachycardia, orthostatic tachycardia. That's out of the ordinary. Orthostatic hypotension. You know, the patient's having the orthostatic lightheadedness. Does your heart rate change drastically? Does your blood pressure drop? Have you taken it? One sort of quick and nice way to differentiate certain types of neurogenic orthostatic hypotension. So orthostatic hypotension stemming from that adrenergic autonomic failure at the bedside is by taking the heart rate, blood pressure, supine, and standing. And the delta of the change of the heart rate divided by the delta of the change of the systolic blood pressure. If that's too little, less than 0.5 or even 0.3, that tells you that the heart rate is not responding as you would expect it for the drop of blood pressure. And that tells you that there may be an impairment of the autonomic nervous system causing neurogenic orthostatic hypotension. It's not written in stone, but it's a quick and easy way to raise your suspicion, maybe do more to further investigate the neurologic problem causing orthostatic hypotension. Supine hypertension, very important to inquire about and ask. When people have neurogenic orthostatic hypotension, frequently they also have a problem where the blood pressure is too high when they lay down, especially when they go to bed. Like with the next point I'm making, abnormal blood pressure regulation with non-dipping or reverse dipping of blood pressure at night. Normally, when we go to bed at night, our blood pressure falls nicely, so we can, sleep. You don't have to wake up and urinate every 10 minutes. In people who have neurogenic orthostatic hypotension, autonomic neuropathy impairment, not only do they have orthostatic hypotension, but they also have supine hypertension. And at night, that could be a problem because with elevated blood pressure, that's going to make you produce more urine, dehydrate yourself all over night, but it can also have detrimental effects over time, including on the heart, kidneys, brain, and so on. Important to note. And then you can also use the standardized testing for autonomic function, such as autonomic reflex screen, which is composed of multiple aspects: quantitative pseudomotor axon reflex test, heart rate response to deep breathing, Valsalva test, and tilt table study, and also thermoregulatory sweat test. And I'll showcase all of that for you through the cases we will discuss together. What does that do for you? Well, it helps you confirm the diagnosis. There is autonomic neuropathy, there is central autonomic failure, and then tells you about the pattern, which then can help you with the etiology. Then obviously a lot of ancillary testing can be done if needed, including laboratory tests that look into common causes such as diabetes, vitamin deficiencies, paraproteinemias, metabolic causes, and so on. A second tier would include autoimmune workups like paraneoplastic panels, tissue biopsies, if there's a large fiber nerve involvement, things like nerve biopsies. If there isn't, and we think there's a small fiber component, things like skin biopsies. A lot of times we also do fat pad biopsies if we're thinking about things like amyloidosis. 24-hour blood pressure and heart rate monitor, ambulatory blood pressure and heart rate, can actually be also a very powerful tool. It shows you that supine hypertension, things like orthostatic hypotension as well, postprandial hypotension, helps you correlate some of the patient's symptoms with actual changes in heart rate and blood pressure, which then would further your confidence that those symptoms actually stem from a problem in the autonomic nervous system versus something cardiac or other causes of dizziness in general. Of course, organ-specific tests, including echocardiograms, gastrointestinal motility studies, and so on, can be utilized when needed. So how does autonomic function testing look? Well, I'll start with the autonomic reflex screen. The autonomic reflex screen is a battery of testing that is more or less a 360 kind of an evaluation of the autonomic nervous system that I regard as an extension of my history and, well, more appropriately, physical examination. Because as a neurologist in the office, really, I can examine much of the nervous system. I examine a lot of the brain functions. I can examine a lot of the neuromuscular system. With the autonomic nervous system, I can examine some of the sensory modalities of the small fibers. Okay, but not all autonomic impairment comes with small fiber or sensory impairment or somatic impairment. I can also examine, of course, orthostatic vital signs, like I said. But beyond that, I really don't have very good measures of what's going on with the sympathetic nervous system controlling sweat or controlling blood pressure. How about the parasympathetic controlling heart rate? So that's where the autonomic nervous system testing, specifically speaking here, the autonomic reflex screen, comes into play. And the first part of it is the pseudomotor assessment, SUDO motor. And that is a sweat assessment. And that specifically addresses the function of the postganglionic, so that's the peripheral part of the nervous system, sympathetic, that's your fight or flight system, but cholinergic, so that's where the sympathetic nervous system uses the neurotransmitter that is otherwise main neurotransmitter of the parasympathetic nervous system, fibers. Okay, the way we do that is we do something called iontophoresis of acetylcholine. We put a little bit of acetylcholine around the skin. We zap a little bit to introduce it to the sweat glands, as you can see here. And then once we've stimulated one sweat gland, it's like a reflex. It's very similar. Most of this test is very similar to your knee reflex. There's an afferent, efferent, there's an arc. And it doesn't go centrally. It only evaluates your peripheral sympathetic, that's both ganglionic sympathetic cholinergic nerve fibers. And then what we actually measure is sweat from the previously dry area, so the sweat gland that we didn't expose to the acetylcholine. And then we measure that sweat, the amount of sweat, then we compare to normals for that site. We put it on the forearm, proximal leg, distal leg, and foot, and age. If it's above a certain threshold, then the nerves, the autonomic nerves, sympathetic, cholinergic to be exact, in that area are normal. So in this case here in red, that's the forearm, that in proximal leg in green, distal leg in blue, and foot in yellow. We can measure how the area under the curve. We get a nice number. We compare it to normals. If it's above a threshold, it's normal. In this specific case, that's a normal result where the sweat volume at all of these sites is normal, telling me that there's no small fiber neuropathy, there's no autonomic neuropathy, specifically sympathetic cholinergic in any of those areas. This test helps us identify things like link-dependent small fiber neuropathy, autonomic neuropathy, and so on. The second part of the autonomic reflex screen is heart rate response to deep breathing. Here in blue is the patient's breathing. We had the patient breathe deeply at 6 breaths per minute. And then in green is the heart rate response. All of us in normal situations, we have something called respiratory sinus arrhythmia. When we inhale deeply, we stretch our lungs and we fill our hearts a little bit more with blood. And there are multiple reflexes in play to prevent the excessive expansion of the lungs or the heart, which then accelerate the heart rate and also stops us from breathing. It's called the Herring-Brewer reflex and Bainbridge reflex. And when we inhale very deeply, we stretch the lungs, we stretch the heart. The response through the vagus nerve is a withdrawal of the parasympathetic function causing tachycardia. So every time the person takes a deep breath, a tachycardia happens and then it goes down. And then what we do is we calculate those responses, and through a little bit of simple math, we generate a number and we compare it to normals. And if it's above a threshold, we know that the patient's vagus nerve is normal. So that's a cardiovagal assessment. That's important to evaluate if you're thinking there's something wrong with the cardiovagal system, such as what we said about diabetic autonomic neuropathy, or people who have problems with the parasympathetic system, including genitourinary and gastrointestinal problems, for example. The third part of the autonomic reflex screen is the assessment of the cardiovascular adrenergic function. And that comes it's very important in much of the rest of our talk today, because this is the part of the autonomic nervous system that you really want to evaluate when you're looking to investigate orthostatic intolerances, orthostatic tachycardia, but also orthostatic hypotension and cases of syncope, to see if those are stemming from a malfunction, a structural destruction or impairment of the autonomic nervous system. And the way we do that is through something called the Valsalva maneuver. And here in the bottom, I hope that projects well in yellow, we have the patient blow in a tube, and it's connected to a blood pressure gauge. And we have the patient blow to 40 millimeters of mercury. Here's the pressure on the left. And we have them maintain a smooth effort for about 15 seconds, and then they stop. What that does, it builds intrathoracic pressure around the heart, the vena cava, and other structures, reducing the blood, the venous return back to the heart, and reducing blood pressure. So once the patient blows against resistance to 40 millimeters of mercury, what happens is the blood pressure drops, as measured through, we have something called the FenaPress, a little bit of blood pressure cuff around the finger, continuously beat to beat blood pressure monitoring. So here in red is a systolic, purple is mean, and then yellow is diastolic blood pressure. So when the patient performs that Valsalva maneuver, the first thing that happens is a abrupt drop in blood pressure called early phase 2. And that is the instigator of everything that happens afterwards in this specific test. That's the beginning of the reflex, the stimulus. Once that blood pressure drops, our baroreceptors in the carotid sense that there's not much blood going up in the carotid anymore, right? And the baroreflex job is to maintain a balanced blood pressure, to maintain blood flow towards the brain. So once that's sensed, the first thing that happens here in green is the heart rate. The first thing that happens, the autonomic nervous system, through the baroreflex, withdraws the continuous break from the parasympathetic nervous system and causes tachycardia. So increases the heart rate, that goes up to increase the blood flow up towards the brain. And we can calculate that the top number divided by the bottom number, called the Valsalva ratio, and that is a good measure of the vagal, that's the cardiovagal, the parasympathetic part of the baroreflex. Okay. That's the easiest, quickest thing for the autonomic nervous system to do. The second, however, once you've accelerated the heart rate, that only goes so much to increase blood flow up towards the brain. Now, the sympathetic cardiovascular adrenergic, right, system kicks in, increasing the blood pressure, called that late phase 2. And when that is good and nice, almost back to baseline, at least on the mean, then that is a good indication of that sympathetic cardiovascular adrenergic system being healthy. Then once the patient stops, now there's no intrathoracic pressure, the blood pressure drops a little bit. Afterwards, however, that adrenergic nervous system is still engaged. It increases the blood pressure back to baseline and then overshoots because it's not opposed by that Valsalva maneuver anymore. And we have something called a Valsalva, a phase 4 overshoot. And by a trained eye of a clinician who reads this, we know that those phases are present. That time for blood pressure to go back to baseline after the Valsalva maneuver, that overshoot is present. We can tell you that yes, the cardiovascular adrenergic nervous system is functioning well, is intact. Then afterwards, we do a tilt table study. On a tilt table, we have the patient rest laying down for about 30 minutes or so to get a good baseline. Here, baseline, we have breathing in blue, heart rate is in green, and then blood pressure is in red, purple, and yellow. Once we've established a good baseline, we tilt. This is the tilt mark. We tilt to about 70 degrees to eliminate the sort of the calf and the thigh sort of pump function. So we load all of that blood down towards the vessels, and we maintain that tilt for about 10 minutes or so. And we monitor breathing, we monitor heart rate, we monitor blood pressure, both through the feeder press, but also manually to make sure we have 2 points of comparison. And we judge for things like orthostatic hypotension, tachycardia, and other phenomena that could happen through that tilt that may explain why the patient is lightheaded or so on. This, in this case, is normal, nice and stable breathing, heart rate, and blood pressure throughout. We can then also, that was the autonomic reflection. We can also investigate the function of the autonomic nervous system a little bit more using a couple more tests. One is called the thermoregulatory sweat test. Remember I said with the autonomic reflection, the part that is called the QSART, the quantitative pseudomotor axon reflex test with the capsules where we collect the sweat, that looks at the function of the nerves themselves, just the peripheral things. Well, how about the whole central and peripheral, also with the ganglia, sympathetic, thermoregulatory system? Can we investigate that? Because we know that there are some cases of autonomic failure. They only stem from the brain. There's nothing wrong with the nerve. And the answer is yes, we can. And that's through something called the thermoregulatory sweat test. We basically lay the patient on a stretcher. We powder their body with an indicator powder that turns purple upon contact with moisture, and put them in a sauna, sort of, and we watch them sweat. Wherever they sweat, they turn purple. Where they don't, they remain yellow. Like in this case, the person sweat throughout. And that allows us to assess the function of that sympathetic thermoregulatory system all the way from the hypothalamus down to the spinal cord, out to the autonomic ganglia, and then to the nerves and the sweat glands. So with the other test, the part of the autonomic reflex gene, it helps us with localization of a problem coming from the brain, spinal cord, ganglia, or nerves. Also, in certain cases where the autonomic neuropathy is associated with somatic small fiber neuropathy, one can utilize skin punch biopsies. There are usually about 3 millimeter punch biopsies at a certain designated areas, like the dorsal foot, distal leg, mid-thigh, and so on. And for that one, H&E and PGP 9.5 stains are used to help identify the small fibers that cross the dermal epidermal junction. By counting those, I hope you can see here the squiggly lines, by counting those and compare them to normal for that site and age and so on, you can say whether or not there is a drop of the epidermal or fiber density in that area. This test also, being a pathology test in certain cases, we also do amyloid staining for this, Congo red. And if there's amyloid deposition in the skin, that can be seen and can help you with the etiology. Now, what are some of the caveats of autonomic testing? No test is perfect. And you, for any test, you really want to know why you're getting the test and what do you expect the test to help you with and tell you before you do it. Some of the caveats are the following. So impairment in one area of the autonomic reflex gene may not explain the patient's symptoms. For example, I see a lot of people come to me and say, well, I'm lightheaded. Really, no one checked my orthostatic vital signs. There's no tilt table study. There's no autonomic reflex gene. But my provider did a skin biopsy, and they said, well, one of those sites, there's a drop in the density, and I got the diagnosis of neurogenic orthostatic hypotension. Well, it doesn't necessarily work that way. A problem in part of the autonomic nervous system may be isolated and may not explain why the patient came to you in the first place. Pseudomotor and skin biopsy locations are limited. So with those QSART capsules, like I said, forearm, proximal distal leg and foot, similarly with the skin biopsy, it doesn't cover the whole skin. So if your patient has burning around the chest, for example, you do a foot skin biopsy, it shows small fiber neuropathy, it may not be the same etiology. Localization and variations of TST. I showed you the one TST that had really nice generalized sweating all over. There are some of us who don't sweat a lot around proximal arms, proximal legs, and so on. So a person who does these studies has to be very well trained to know what are the normal variants and not overcall pathology. And medication effects. A lot of patients do get autonomic testing with really bad results, will get diagnosed with autonomic failure where it was overlooked that they took a medication before the test that would disrupt the function of the autonomic reflex, autonomic function, such as things like Wellbutrin, for example, commonly used would cause anhidrosis on the test. There's nothing wrong with Wellbutrin, but if you take it before you go to your sweat test and don't sweat, and you don't tell the doctor, they may say, oh, you have autonomic neuropathy while you had medication effect. Similarly, if you take a blood pressure lowering medication and you have a drop of your blood pressure on that Valsalva or the tilt table, it may not be, it may be all the medication effect. So those things are very important to screen, and good labs usually try to do their best to do so. However, there are some suboptimal commercial tests available out there. So one has to be careful where to send, certain things, including skin biopsies and autonomic testing. And like I said, high pretest probability of autonomic impairment gives you probably the best results. All right. Now that we have done a little bit of an overview about the approach and autonomic testing, let's delve into some case discussions, and hopefully we'll make some of those points a little bit more clear. Again, we'll focus on orthostatic intolerance, hypotension, tachycardia, and also some cases of syncope. The first case is of a 60-year-old with diabetes mellitus type 2 for about 10 years, less HbA1c of 10. There's end organ sort of complications, including sensory neuropathy, nephropathy, retinopathy. The patient presents to you for evaluation of orthostatic lightheadedness and pre-syncope. So I come in and said, on my feet I feel lightheaded. I need to sit down frequently. If I get up from sitting too quickly or get up from bending forward too quickly, I may lose my vision a little bit. I need to sit down frequently after long walks and so on. You ask about other autonomic problems. Can you adapt your eyes to lights? Is there any problem with the genitourinary system, sweat, and so on? You get, oh, well, I do have constipation and early satiety and some weight loss. So you think maybe gastroparesis or paresis. On your examination, you do orthostatic vital signs. And in the office, you note that there is supine hypertension, so about 160/100 blood pressure, heart rate 77. And upon standing within 1 minute, you get a drop in blood pressure, prominent, more than 20/10 down to 100/60. Patient is symptomatic. Interestingly, the heart rate doesn't really respond. It's quite steady, as if nothing happened. And that raises your suspicion that it is orthostatic hypotension, and that orthostatic hypotension may be neurogenic orthostatic hypotension. Now you're connecting the dots together with diabetes and so on. On your neurologic examination, you also find that there is evidence of some length-dependent sensory motor, primarily sensory neuropathy with pamidality loss to pinprick vibration, position sense, and light touch, and the feet, and absent ankle jerks. You can do some more neurologic things, nerve conduction study, EMG, and this particular patient, as known by history, does have sensory motor peripheral neuropathy, large fiber on the EMG. But the EMG doesn't investigate your autonomic nervous system. How does his or hers, so that person's autonomic nervous system testing looks? The assessment of the sweat here is done through two tests. One is the QSART, postganglionic pseudomotor sympathetic cholinergic function, and we can see that the forearm, proximal leg, they're normal volume. Okay. However, when you go to the distal leg and foot, the volumes are reduced, and that tells you that there is a length-dependent postganglionic pseudomotor impairment. Okay, the small fiber autonomic. We do a thermoregulatory sweat test, and we find that there is loss of sweating around the same areas in the feet, also a little bit asymmetric in this case, down up to the left leg. A lot of those people have things like neuralgia paresthetica in the past that they may not have been very symptomatic. So we can pick up on some of those things in a TST. And also thoracic radiculopathies are not uncommon in diabetics as well. We can pick up on that with TST. But what we're seeing here is that there's definitely an impairment of the sympathetic pseudomotor function. The second part of the autonomic reflex screen looks at the cardiovagal assessment. So we have this patient do that deep breathing exercise, 6 breaths per minute, and we look for some heart rate response, and there's really very little. So you remember I showed you where the variation is really nice, kind of similar to the patient's breathing. This one, very little variation. So that tells you that there's a cardiovagal impairment, okay, cardiovagal impairment in sort of cardiac denervation. We look at the cardiovascular adrenergic assessment, and we see that when they do a Valsalva maneuver, that blood pressure drops, but then that sympathetic nervous system doesn't kick in. You don't get that nice late phase 2. That's normal. I'm going to show you normal. That phase 2, it goes up. Here, it doesn't. You don't get that nice and quick blood pressure recovery after the Valsalva maneuver. It takes forever, right? And you don't get that heart rate response to the drop in blood pressure called the Valsalva ratio. So you see this, and you know that there's impairment of the baroreflex, both the vagal and the cardiovascular adrenergic components. Now, when you see this, that on the next screen, tilt table study, you're going to have supine hypertension, around kind of 150s, 160s, but orthostatic hypotension. So we tilt the patient up here, that's tilt, and they only last for about 2 minutes on the tilt table study. Abrupt progressive orthostatic hypotension, very little heart rate response, that's neurogenic orthostatic hypotension. So this case is of diabetic autonomic generalized, right? Sweat, cardiovagal, the parasympathetic, cardiovascular adrenergic, the sympathetic, with neurogenic orthostatic hypotension, diabetic autonomic neuropathy, okay? The way we report these on the actual report of the test is we talk about each and every one of those parts. We say there is length-dependent postganglionic sympathetic pseudomotor. Again, that sweat part. The severe cardiovagal, that heart rate variation with deep breathing and Valsalva ratio is not there, and there's severe cardiovascular adrenergic impairment or failure with neurogenic orthostatic hypotension, which in this case, having looked at other potential etiologies, seems to be stemming from diabetic autonomic neuropathy. Well, now that you have identified neurogenic orthostatic hypotension as the cause of the patient's orthostatic lightheadedness, how do you treat orthostatic hypotension? It starts with conservative management. Okay, you have to expand the volume, 80 to 100 ounces of water a day. You have to have the patient hold on to their water by increasing their electrolyte intake, sodium and potassium, 10 to 20 grams a day. Okay, a good way to measure if you are questioning whether or not your patient is taking their sodium is to do 24-hour urine sodium, and you should aim for about 170 millimoles per 24 hours of sodium and about 1,700 mLs of urine output. That usually indicates a good intake. On occasion, people can do tricks where they chug or guzzle down 16 ounces of cold water. That's going to increase your blood pressure for about an hour. I tell people not to overdo this. It's called water bolus therapy. A couple times a day as needed, since overdoing it may lose its effect. Every time they stand, they need to stand up slowly, apply counter maneuvers. Make a fist, noodle your legs, squeeze your abdomen. They also should consider wearing compression garments. To me, the best is something that covers rib cage to knees, gets nicely that splanchnic vasculature and the thighs, okay? And they definitely should exercise, both cardio and strengthening, focusing on those core muscles. A lot of times we have them start exercising in the recumbent manner. So recumbent bike, rowing machine, swimming, because you don't have to be up on your feet, so you don't drop your blood pressure, and that gets you in a better conditioning. Once you've optimized conservative management, now you can work on pharmacologic management, okay? And that includes medications that would cause vasoconstriction, such as midodrine, which is an alpha-1 agonist, or droxidopa, which is a norepinephrine prodrug. These work similarly. I tell the patients, you wake up in the morning, you're still in bed, you take one of the, whichever one you're on, pill, you stay in bed for about 20 minutes with a good amount of water, and then it starts working, then you get on with your day. In the case of midodrine, it works for about 4 hours. droxidopa about 5 hours. If you still need to be up on your feet, you redose up to 3 or 4 times a day. And you should never take these within 4 hours of going to bed, with increasing chances of supine hypertension, especially with midodrine, but really you should be cautious for both. Fludrocortisone can also be used to increase blood volume as well. And pyridostigmine or mestinon, which is a medication that increases the availability of acetylcholine in the body, can also be utilized. It can help with things like gastroparesis as well. For supine hypertension, we have the patients tilt the head of the bed up by 4 to 6 inches. I'll show you a picture here. That causes a little bit of a drop of blood pressure at night. And sometimes some of these patients will need to have a blood pressure lowering medication before bedtime that is short-acting, such as losartan or nifedipine, which would help drop the blood pressure even further, again, to avoid those potential harmful side effects of supine hypertension. Some of those patients have postprandial hypotension, which is a drop in blood pressure after eating. The management would be small, frequent meals, drink a large cup of fluid with meals, sometimes a little bit of coffee, sometimes abdominal binder around meals, and also, on occasion, we pre-medicate with a small dose of midodrine. So that was orthostatic hypotension. Let's move on to another case. A 32-year-old presents to your clinic after severe upper respiratory infection about 2 months ago. Now having syncopal episodes with constant dizziness upon standing and occasional palpitations. The patient has constant nausea and daily migrainous headaches. We go on and do some autonomic testing. We see that the pseudomotor function is normal. The sympathetic postganglionic pseudomotor function, the sweat is okay. Sweat test is also normal, so that part of the autonomic nervous system looks okay. We do heart rate response to deep breathing, and you can see that the heart rate responds very nicely, so the cardiovagal function is okay. And we even do Valsalva maneuver, cardiovascular adrenergic function is also normal. So the reflexes themselves, at the moment, reflect no evidence of autonomic failure or neuropathy. However, we do a tilt table study, and we find that while the blood pressure here in red and yellow continues to be normal throughout the tilt table study, the heart rate starts about 75 supine and 115 then, and continuously so upon tilt, associated with symptoms of orthostatic lightheadedness, tachycardia, and so on. And that is POTS. That's symptomatic orthostatic tachycardia. Okay. The diagnostic criteria are heart rate increment of over 30 beats per minute upon active standing or tilt table study. Absolute value around 120 beats per minute with that tilt table study. You don't necessarily have to meet the absolute value. You should have, cross that threshold and maintain it. It's preferable to cross, get to that absolute value, but not everyone does. For pediatric criteria, persons less than 19, it's heart rate increment of over 40, okay? Over 40 and maintaining it. Several subtypes, POTS can be neuropathic. It's usually very subtle, mild, cardiovascular adrenergic, or sympathetic, can sometimes be seen on the pseudomotor testing, impairment, a lot of times post-infectiously or after vaccinations or so on. And then by the time of testing, we might still pick up on some of these findings on the test, or it may have improved, but the phenomenon that is left is that orthostatic tachycardia, okay? However, we have other subtypes, including what we call hyperadrenergic POTS, where there's a little bit too much sympathetic activity, and we can sometimes test for that with elevation of standing norepinephrine level of over 600 picograms per ml. POTS can also be a product of chronic conditioning and can be associated with other comorbid conditions, including chronic fatigue and pain syndrome. Management, exercise. Really that, start low, a few minutes a couple times a week, recumbent exercise, and gradually increase that effort over 3 to 6 months to about 30 minutes every day, or even more, depending, is key in POTS. Because a lot of it, like I showed, doesn't come with a tremendous amount of adrenergic impairment or autonomic failure, but it's a lot of rebuilding those neural connections between the brain, the heart, the cardiovascular system, slowly but surely, that helps these patients. Everything else that I talked about in terms of orthostatic hypotension applies with expansion of volume and compression and so on. We have gravitated away from forcing too many medications on these people. However, sometimes you do need to use certain medications, including beta blockers to lower heart rates and so on, and sometimes even medications to increase blood pressure, depending on the specific case. Well, how about some cases of syncope? You have a patient comes in for loss of consciousness, and you decide it seems to be stemming from cerebral hypoperfusion, right? So drop in blood pressure, excessive increment of heart rate that reduces blood flow towards the brain. How do those look on autonomic testing, and what are some of the scenarios we encounter in the autonomic clinic? Condition 1. You have a 37-year-old presents with history of loss of consciousness spells around procedures. So blood draw, a dental procedure, they get spells of loss of consciousness. Autonomic reflex gene shows normal autonomic reflexes, and that's the blood pressure and heart rate response to Valsalva maneuver. There isn't cardiovascular adrenergic failure, okay? On the tilt table study, however, you see that we start here at a nice blood pressure and heart rate, nothing, out of the ordinary, within normal, around 80 heart rate, 130 blood pressure. We tilt the patient. Initially, you find that there is a little bit of increment of the heart rate and the blood pressure, as if the patient is bracing themselves to something that's going to happen. They're trying to kind of keep that blood flow up towards the brain. Then you see a rather quick concomitant drop in heart rate here in green down, and blood pressure in red, okay? Associated with everything the patient usually gets when they have their spells. So dizzy, nauseous, short of breath, some discomfort in the feet, sweaty, hot. What's that? Vasovagal syncope, okay? Also known as cardiogenic and cardioinhibitory reflex syncope. The way you know it is concomitant drop in heart rate and blood pressure. And the mechanism is overactivation of the parasympathetic system, that vagotonia, okay? That kind of break that the brain is trying to impose on the cardiovascular system. It can be triggered by certain emotional, physical stressors, pain, changes in blood volume, dehydration. So the brain suspects that the blood pressure is going to drop no matter what. You don't have enough volume. Let's just drop it. Increase that vagal tone, drop on the floor. Gravity will take care of the blood flow. Sometimes blood loss, reduction in blood pressure, or increased heart rates. Treatment, of course, expand blood volume, get those triggers under check as much as possible. Case 2. A 20-year-old with known history of epilepsy presents for new morning convulsive loss of consciousness spells triggered by orthostasis. A little bit different than their usual spells. It has, they stand up, then it triggers a loss of consciousness. But this convulsion with history of epilepsy, you're thinking, maybe that's actually a new type of seizures. However, the epilepsy evaluation shows that those are not epileptic. You suspect convulsive syncope. You do an autonomic reflex gene, reflexes are normal, so cardiovascular adrenergic function is fine. But you do a tilt table study, and you see the following. That you tilt the patient, slowly but surely, you find that blood pressure to drop slowly. Now, the brain is calculating that blood pressure drop is ongoing. I'm not able to do much. Heart rate doesn't go up much. The brain didn't activate that part of the system. But then you have that abrupt concomitant drop in blood pressure and heart rates. And the patient has convulsive syncope. So they've had the same spell they usually have at home. And that is a case of vasovagal syncope with slow decline of blood pressure preceding, okay? So in this patient, make sure that blood volume is expanded, make sure they avoid standing still too long, and so on. Case 3, 23-year-old with chronic fatigue and pain syndrome presents with presyncope and syncope. The autonomic reflex gene again shows normal reflexes, but there's some evidence of hypovolemia and poor vasomotor tone. The squeezing is not as good. Sometimes we see it in people who are hypermobile, for example. In this specific case, you tilt the patient up, and right away, you have an increment of heart rate with some decrement of blood pressure, very abrupt, very quick. Could be partially because of anticipation of wanting to pass out, so they're really trying to engage the system, but that doesn't work. And then they have a very abrupt drop in blood pressure and heart rate right after. So that is vasovagal happening after prominent tachycardia. So chicken or the egg here. Is the tachycardia the problem? Is the blood pressure? Is that a part of the reflex itself? No matter what, however, in this people really have to focus on counter maneuvers, standing up slowly, okay? Mitigate what's going on with the heart rate. Is there a lot of anticipation? Help them reduce that trigger to prevent then the reflex syncope from happening. Again, another type of vasovagal. Case 4, 60-year-old with history of syncope due to episodic bradycardia, long cardiac pauses, had a pacemaker placed. That's going to resolve everything, right? No, they continue to have syncopal episodes, okay? So this person has autonomic reflexes are okay, but because they have a pacemaker, we cannot judge the cardiovagal function very well, okay? Why is this patient passing out? They had their pacemaker. It's a common scenario I see in the autonomic clinic. Well, here's why. Although this patient does have a pacemaker, and you see they're nicely paced, they're not allowed to drop beyond 70. When you tilt them, they start slowly dropping their blood pressure. So they have slowly, very, slowly, not a big of a deal, but the brain is perceiving that. It's trying to increase the heart rate. They're not pacemaker dependent completely. So the pacemaker allows for an increment of heart rate. But at the end of it, once the brain decides that we have to enforce that reflex, it drops both heart rate and blood pressure. Heart rate cannot drop beyond the paced rate, but the blood pressure can. And that's how a patient with a pacemaker still passes out through a vasovagal mechanism. Quickly, a couple more conditions. 56-year-old presents with hyperhidrosis and occasional presyncope with prolonged standing. Autonomic reflex gene, normal reflexes. Now, in this particular case, you tilt the patient, the heart rate throughout continues to be normal, okay? Doesn't drop, it's stable, around 66. However, slowly but surely, and then abruptly, the blood pressure drops, delayed manner. This is not neurogenic orthostatic hypotension because the blood pressure response to Valsalva maneuver is normal. However, this is what we call vasodepressor syncope. And rather than an enforcement of the vagal tone, like in vasovagal, this is a withdrawal of the sympathetic tone that can happen slowly. And for this one, you should focus on the vasomotor constriction. Sometimes you could, help it with reconditioning and exercise and compression. Sometimes you need to have something like a little bit of midodrine to help with that vasoconstrictive ability. Well, can you see combinations of a couple conditions on a tilt table study? The answer is yes. He's a 14-year-old with orthostatic intolerance, palpitations, and presyncope, autonomic reflex gene, normal reflexes. But here's a tilt table study. What you see is 40 beats per minute or more increment of heart rate upon tilt, so that's POTS, followed by, at the end of the study, a prominent drop of blood pressure. Remember, POTS itself doesn't cause a drop in blood pressure, it causes symptoms with heart rate increments. So this is POTS, and then the brain perceiving too high of a heart rate, going to be in trouble, drops the blood pressure by withdrawal of the sympathetic function, causing vasodepressor syncope. And sometimes you can call this also POTS followed by hypotension or delayed hypotension through a vasodepressor mechanism. So you really want to help this person with vasoconstrictor rather than dropping their blood pressure with a beta blocker, reducing that adrenergic function. And this is a 22-year-old who presents with orthostatic lightheadedness, just found that she's pregnant. And you see that here we have the following. You increase the heart rates upon tilt right away. Okay, so here's the tilt, heart rate. Heart rate goes really abruptly high by about, over 40 or so, okay, beats per minute, around 40, okay? And with that, right away, there's a mismatch between the cardiac output, total peripheral resistance, causing transient drop in blood pressure early on here. So the heart rate goes by 40 very quickly. Blood pressure drops by about 30 or so, kind of 22 millimeters of mercury, and then it rebounds. Because this patient does not have neurogenic orthostatic hypotension. They have POTS with that quick, early sort of, and then recovered orthostatic hypotension. Again, in this person, those counter maneuvers and so on would be useful, also managing the heart rate increments. So see, there's combinations that you can pick up on testing that may allow you to, well, make the diagnosis, but also direct your care a little bit more specifically for those patients. The autonomic nervous system helps link discrimination and racism to chronic illnesses. There is a body of literature that suggests that African Americans and those in lower socioeconomic classes have lower heart rate variability than more affluent citizens. Heart rate variability, I didn't talk about that a lot today, but it is a measure of the health of the autonomic nervous system. Normal, higher levels tell you that there is good parasympathetically led nervous system, autonomic nervous system. Heart rate can varies in different situations. If you are under a stress, economic or otherwise, right? For long term, your sympathetic nervous system kicks in, right? That's linked with chronic stress and a lot of other problems, but it can also show that your heart rate variability is lower, and that can, sort of help increase our awareness to certain health disparities when it comes to the autonomic function. There are some sex differences that shown in certain autonomic conditions, including in younger individuals with things like POTS and also certain types of reflex syncope, versus older individuals with things like pure autonomic failure who may be more male. My colleague, Dr. Elizabeth Kuhn, also has done some studies in multiple system atrophy and sex differences, and has shown that in MSA, men had more severe autonomic failure, while women had earlier falls, and survival also favored women. And those things are useful to consider when seeing those patients with these conditions and counseling them. With that, I will end my talk, and I'm happy to take any questions. Thank you so much for listening.
Great. Many thanks, Dr. Schumann. Super informative. I'll start with a couple of comments and questions from our online audience here.
Right.
One you may be able to speak to in general terms, though not specifically. There's a couple of comments acknowledging challenges in accessing diagnostic and management tools for patients with autonomic dysfunction, and that perhaps even at our university program of OHSU in town, accessing expert help or tilt table testing is not readily available. So any general comments on that would be great. And then maybe building off of that, as often managing these conditions in the primary care setting, any wisdom for patient communication and particularly sort of acceptance of an autonomic dysfunction diagnosis as sort of real, and avoiding sort of exhaustive additional workup.
No, that's absolutely a very important point, and I do acknowledge that autonomic access to autonomic testing is not necessarily available everywhere. The reason why my talk was focused on autonomic testing is basically to showcase it and not to suggest that this is the only way to evaluate for autonomic dysfunction. To your point, things like just good old medicine, right? Good history, good general exam, a little bit of neurologic examination, orthostatic vitals, some of those tricks with the heart rate changes, listening to the patient really goes a long way. Sometimes you can also, if you want to do more testing, you don't have tilt table, but maybe you have a blood pressure cuff. You can do a little bit of ambulatory test, maybe 6 hours or 24 hours. Really gives you a lot. I didn't show it a lot today, but it gives you a lot of similar information in real life situations. Okay, and definitely autonomic dysfunction is real. You can, a lot of those patients have been told that it's in your head. I think acknowledging that they do have a problem and that there are some things that we can help them, even if it is more water and exercise and salt, really goes a long way. So first, hearing the patient, acknowledging that they have a problem and that there are some things to be done. A lot of times that goes a long way, and actually also their not only understanding of what's going on, but also sort of collaborating with you on helping themselves.
Great, thank you. That makes a lot of sense. Along those lines, I'm not sure if you have any specifics with regard to patient education resources, or how navigating the logistics of something like volume expansion, sodium and potassium intake, where to get binders, anything useful out there.
Yeah, well, we actually in our clinic we have a little bit of folder we give people. I usually walk you through it as well, but today I wanted to show you a little bit more cases than others. We do have some resources, places like Mayo Clinic online, and there's also this Autonomic International. They have a really nice organization, and they link you to a lot of resources and providers in your area sometimes.
Great, thank you. I'll acknowledge we have just 1 minute left before the top of the hour, but curious if there's anything that you've specifically noticed in the post-COVID era as we're encountering patients with long COVID and the like. Any comments there?
You bet. We actually were the first group to publish the post-COVID autonomic dysfunction and early experience. So a little bit plug for my paper if you want to take a look at it. However, since then, so early on, that was more of a post-infectious phenomenon. I had suggested that some POTS can be post-infectious, different viruses. Now it's really gotten very complicated because now we have post-COVID long haulers. They can be chronic fatigue or orthostatic tachycardia phenotypes and a lot of complications. But suffice to say that it really runs the gamut. We see all sorts of, post-infectious neuropathies, orthostatic hypotension. Here's a nice thing that I've noticed a lot. A lot of those patients have had some of it before. So a lot of patients have a little bit of POTS-C, a little bit of orthostatic intolerance prior to the COVID, and then it brought it to attention. Don't forget about that piece of sort of history. It really helps you evaluate them and counsel them.
Great. Well, clearly a large topic, fascinating, and we could talk on, but we are at the top of the hour. Thank you so much, Dr. Schumann.
It was a pleasure and honor. Thank you so much for inviting me. You guys take care. Have a great day.